All right, here we go. In case anybody bops in, they'll be able to look at this as well. This is kind of where we left off talking. And so I'm going to principally go through the protein synthesis categories. That's really what today is about, more than anything else. Because once we're done with them, and then the other different categories that are about it. But Vanco, the take-home point, it's not active orally. We use it orally to clean out the gut if we're going to do like bowel surgery. Because that way, when you cut into somebody's bowel and take out a piece or reroute it and things like that, I took Vanco for that purpose way back 30 years ago when I had major bowel surgery. Okay, so that's just gives you an idea. And again, and we'll get to the important portion about severe C. diff and where problems have come because of treating it like this. It is very interesting. There's a much better agent that was there before to treat C. diff. We will get to that today as well. So, I thought I'd put that in there, not active orally, absolutely can't work on gram negatives, nothing they can do to it, but it's really important. Bacitracin is topical, part of Neosporin, triple antibiotic ointment. All of these are this is really the major category that's left. Protein synthesis. The vast majority of these categories are all relevant, they're all important, and they're all utilized in some way, shape, or form today. Some of them, they have to be utilized because this is where the quote drug of choice, which is what you're supposed to use to treat MRSA. I beg your pardon, the drug of choice for people who are allergic to penicillin. I have MRSA on my brain. So these are all, and I don't care if it's the 50S or that 30S or where it attaches, just know that it impacts protein synthesis, and there's always side effects, and they're almost always gastrointestinal, and because it targets 70S ribosomes, which are in our mitochondria. I know I've said that a million times, but it's so terribly important. The first category was the second antibiotic that was discovered. It's called, and we use the categories just like antiseptics and disinfectants and germicides. Understand that the categories, and that's the way they're going to do it with nursing as well. The category names may differ a little bit for their purposes, but not that much. Aminoglycosides. This was a soil bacteria. This was what Selman Waxman found. It came out of Streptomyces, and the one we hear the most about is Streptomyces. They are rarely used today, except one very significant clinical condition. They work extraordinarily. You see the limitations. Don't work so well against anaerobes, enterococci, which we may not get to today. We'll talk about streptococci. Enterococci are a cousin, so it's not something you give somebody for a strep throat. It requires respiratory metabolism. So this is basically for organisms that are aerobic. Okay, and yeah, sometimes when we used to do, we'd use penicillin and streptomycin when we didn't have a whole lot of other choices. When I started doing this stuff effectively 50 years ago. Okay, to give you some idea, it is a real problem. The side effects are extremely difficult. Most of the time when we use the original player in this, streptomycin, is probably used to treat when you're kind of running out of drugs to treat tuberculosis. Just to give you an idea, you're using this in difficult cases. So this category, the big problem is toxicity, and there are two for the aminoglycosides, and they have to be dealt with and recognized because we do use one member. So they are renal toxicity, they damage your kidneys, and ototoxicity, they affect your hearing. The agent that we use today, because it is one of the most difficult, you've already started to hear this, called Pseudomonas. It's called gentamicin. That's the one we use probably the most. And it's only by injection. So it's not something you can take a pill for. So I think that's a very significant feature, but by using that, you have to address these toxicities. Kidneys, when kidneys don't work, when you get to renal, for many of you in AP2, one of the kidney's most important jobs is getting rid of nitrogenous waste. we have a very limited capability. Nitrogen is a big problem. Urine is made of urea, that's discarding nitrogen. Uric acid, that's discarding nitrogen. So nitrogenous wastes have to be accounted for. You'll learn, many of you going forward clinically, there are two tests. One is called BUN, blood urea nitrogen, and the other is called creatinine. Don't know that. Creatinine is a breakdown product for that for the creatinine that we utilize in muscles that many of you had me for AP1 might recall. We measure those in the bloodstream. Typically every other day, if we have a patient who has this, they have to come in. We monitor it. If we start to see those numbers go up, meaning your body's not getting rid of it, we have to do something about this agent or find another one to reduce. So you have to do something with the dosage. Hearing's more difficult. And particularly if you give it to somebody who's getting older, a lot of times they're hearing a little sketchy too. Maybe it doesn't matter as much, but I mean, that's a value judgment. And so a lot of times it's, it's almost like if you start to see a patient, all of a sudden you're talking to them and they're like, and you knew they could hear you perfectly before. Now that's, it's sort of like, and the people who interact with them the most are nurses. That's not even a question. That's just a general statement. So I really want you to recall that. This is the type of thing that works so well against gram negatives in your gut, because they are facultative. They're aerobic organisms. They work in both. And so when you have a burst appendix, this is the kind of stuff. When somebody has a gunshot or a stab wound, this is the stuff. Somebody has a tumor rupture, genitourinary or digestive tubal passageway, and you get all these bad bacteria in the gut. You got to flush it out. That's when you use this stuff. Those are critical cases. Just to give you an idea. So they're a valuable category, but limited uses today, I would dare say, with the exception of the gentamicin. Now, topically is a different thing. I had these, I was getting gentamicin eye drops, for periodically we get them when the kids got conjunctivitis, things like that. So penicillin was first. It came to everybody's attention. Then was the streptomycin, the aminoglycosides. And the next thing they found, everybody thought was the next wonder drug for antibiotics. It would take care of the common cold. Tetracyclines came from the same soil kind of bacteria that streptomycin came from. In the old days, when it first came out in the 50s, it was called terramycin. And we thought back then, the doctors did. I mean, I was a little kid getting this stuff. Reversibly binding, don't matter. Prevents translation, don't matter. Here's the beauty of it, why it works. It gets into bacterial cells, but not our cells. And yes, there's resistance. And this is another good thing about it against certain gram positive and gram negatives. Oh, I did this in the other class. One other thing with aminoglycosides is very unusual in these antibiotics that do protein synthesis. It is bactericidal. That is a big plus. Pretty much all the other ones, with maybe one exception, or two exceptions, are bacteriostatic. So the big problem with tetracycline, yes, you can use it for staphylococcal infections and streptococcal infections and gram-negative infections. And the reality is it doesn't work that great. It is not, it is broader in spectrum, but it's not particularly have a large spectrum of activity. It's just not, for a routine staphylococcal skin infection, wouldn't be very helpful. For a strep throat, not so great. So why is it relevant? Antibiotics are very unpredictable. Right after 9/11, we had a scare of anthrax. That was actually, we thought it was foreign terrorism, it was domestic terrorism. That they were basically engineered into powdered anthrax. A few people died. There were like letters of powder came out and inhaled it. And a handful of people died. This was one of the drugs of choice. Okay. If you have Lyme disease, this might be a drug of choice. If you have walking pneumonia, this might be a drug of choice. So, I mean, it's got a lot of value. If you had Rocky Mountain spotted fever, I think it's the drug of choice, which is nothing to tinker with. And we'll look at that when we get to skin disease. Not that there's more here than the Rockies, but that's a whole other lecture. So you can't paint with the proverbial broad brush. But we found out early on it was okay. Some students have used it because we take it in mini doses along with erythromycins, basically as a, I'll get one more after this, like mini dose, which means subclinical doses, but you can take it daily for acne. And the one that you'll hear the most about is called vibramycin. I know why they use all those mycins. It's also known as doxycycline. And doxycycline has got a lot of usage by people who chose to use that during the COVID. There was a lot of controversy about whether it was all vaccines and blah, 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 versus using hydrochloroquine and vibramycin. Frankly, there was a lot of success doing it. Same thing with things like ivermectin. You may have heard this stuff. Many of you back in the COVID. Do not go on a rant today. I won't. But that's what I mean. Now, it doesn't sound that bad, does it? Here's what you can't do with it. You can't use it on little kids. It does something. Little kids have growing bone, but more importantly, they have growing teeth. We call those hard structures, okay? And they require calcium. And what tetracycline does in growing, typically before the secondary teeth come in, it chelates. It's a fancy term for latching on to the calcium. It pulls it out. It's a chelating agent. We use chelating agents to like pull bad things out. This is a big problem. When the permanent teeth come in, they're discolored, deformed, and it's a major, not just a cosmetic problem. This is not something that bleaching or whitening will deal with. We're talking major cosmetic implications. And if you're not familiar with those are pricey. And they ain't covered by your insurance. So this is a must do. This is the kind of thing you would see on a licensure exam. What drug do you not do in pre-adolescent children? What antibiotic? And the slam dunk answer is tetracycline. If you look up tetracycline in kids' teeth, pre-adolescent teeth, you'll see pictures that you won't want to see. I am not enough familiar with these glycylcyclines. They've been around for a while. One is approved, and I mean, it's in the same category. I wouldn't ask you about that. This is, of the ones I'm telling you about, certainly the one we use the most. They're called macrolides. Yeah, the big player in this, and this is by definition, and everything I was ever taught, the drug of choice for people who are penicillin allergic. Penicillin allergy. Category is macrolides, and the one that was there the longest and has been is called erythromycin. Erythromycin, because I there's a condition, erythromycin is red, and there's some kind of red pigment that I think is associated with the soil bacteria that comes from a similar one as strep. Different category. What I mean by drug of choice, and I've said this before, if you're doing addictive diseases, drug of choice is when you ask a patient, heroin, cocaine, what is their drug of choice? Clinically speaking, drug of choice means what you are supposed to use. I know I say it multiple times. It's so important. What you're supposed to use. And you better have a good reason not to use. Okay, so if someone's allergic to penicillin, this is the drug unless there's some other mitigating factor. Well, it's not sensitive on the culture, so it's okay. Well, they're allergic to that also. That happens, fine. Always have to have a good reason behind those things. The big problem with this is twofold. It's originally formulated, you had to use typically one pill 4 times a day for 10 days. 40 pills. That is called compliance. It is very difficult. It's easy to skip a dose. And by the way, an antibiotic, well, I missed the afternoon in my life. I didn't want, I'll just take 3 at bedtime. Actually, that's not because of their half-life. You must take them at the appropriate time. And I've missed them. You've missed them. We all have. Maybe you didn't, but I've taken enough over the years to miss them. That's why we like things we take once or twice a day. That more important. That's coming your way. The other problem, other than compliance, was that inevitably people got diarrhea. That clavulanic acid stuff, they figured to make something like Augmentin. When they tried to mix it with, and I was there when it came out with this stuff. The erythromycin, you couldn't tolerate it. Oh my God, people, a few days, they're just dying in the bath. And so I'm not making, I know I presented it, tried to present it in a humorous manner to remember, I'm not making fun of it. This is nasty stuff. Older people, little kids can die with it. They don't do well with fluid and electrolyte imbalance. So long story short, you had to use it and you had to take precautions and make people aware. And, again, probiotics, prebiotics, whatever. Take a bunch of yogurt. So Pfizer Labs came out with this. They took erythromycin and they made something called azithromycin. You'll see the name of those charts that are in this PowerPoint sequence. Go backwards. That is known as the Z-Pack. What they did is they altered the half-life to make it easier. And you only have maybe you've taken it. It only has a container has 6 little capsules, 2 the first day in the morning, 1 the next, 1 the next, 1 the next. So in 5 days, you take 6 capsules, 2 the first. We call that a loading dose. And that's enough to last for 10 days. Easy to comply with. And magic happened for Pfizer Lab. All of a sudden, when they changed the way it was taken like that, much less problems with gastrointestinal. A win-win, easy compliance, less side effects. That's a very famous CPAC. That is a useful drug of choice, just like tetracycline for walking pneumonia. That is a useful drug of choice for people who are allergic to penicillin, for things that might require penicillin, even a staph or strep. It's mostly gram positives, some selected gram negatives. Trouble is it's bacteriostatic. And that was always the problem. Again, when someone says allergic to penicillin, immediately you're taking away your weapons. And nobody likes that. But I think it's a really important category. I can't emphasize it enough. It doesn't work on those gram-negative gut bacteria. That's what it is. And certainly there is resistance. So also, this is another one where you hear about something called, they'll take mini doses of erythromycin, just like they'll take mini doses of tetracycline, frequently for acne. Because acne, we'll learn about in skin diseases, has to do with a bacteria we find on the skin in a number of people who have certain other conditions that predispose them. But you don't really have to go full bore with all the antibiotics, and you can avoid all those GI complications. Acne is tough to treat. I was lucky. I didn't have, my sister and I didn't have the issues that a lot of people have. You start getting things like, familiar with Accutane, and people have to say, oh, geez, that's bad. That's bad. No, that's bad. My stepdaughter they wouldn't release the prescription unless she had a blood test for pregnancy that day at our local hospital. At that time, it's a long time. And, at least, she was in high school. She was 20 years ago, maybe. And then they'd call, we got them at the Walmart in Cranberry, and to get the blood test done in Cranberry, they called them to say, okay, release it, go get it. Because of implications for pregnancy, and that's not the only complication. It actually makes it worse first. Don't get me started on pharmacology. It's fun. All right. One historically, chloramphenicol. No, I probably don't even ask about it. But this is to let you know that sometimes we run into things that are unexpected. Actually, it's a very good agent. When I was around, we used it. They found out in the 60s, and by the early 70s, nobody would use it, that it is bacteriostatic, but it was really broad spectrum. It really worked well in a variety of, but now I don't even think it's a drug of last resort. The last time I saw anybody, I even used it was topically in something to do wound care, things like that. Aplastic anemia effectively means it destroys your bone marrow. And even though you lose both red cells and white cells, the white cells go faster. There's less of them. Okay, you have 1,000 times more red cells than white cells, and your white cells fight infection. And people would die, just like they do with leukemia and things like that, or HIV and AIDS, of infections, because effectively your immune system collapses. And I do not, and at the time, we didn't have the availability of bone marrow transplants, and I do not know if they would be effective because no one ever, there were things that were just emerging on the horizon when this was banned. So rather than bring back an agent, they just basically did away with it. So by it's chloramphenicol, there's nothing called chloromycetin, to know any of that stuff. It's just here. I can't help it. I was telling my sister, who's going to be 81, and she's pretty smart. And it's like, and I'm saying, you remember when we did this? And she's going, oh, how did you remember that? I said, it's what I do. She goes, and then it's like, yeah, now I remember. Mom and Dad was without exaggeration, I'm two of her. Don't start. Any of you. Not you either. Moving on. This is the next category. This is the next one. This is these four. And again, I'm not going to ask you about it. We're going to get to the sulfur drugs, which work by a different category. This is where we find clindamycin. They're called lincosamides. And a recurrent theme for a lot of these is diarrhea. The category are called lincosamides. They are very important for this. The one you'll hear about is called clindamycin. I have extensive use of it because it targets, ready? Anaerobic infections, even though I think there's a better agent. Anaerobes. Anaerobes are tough to get after. Most of these medications are effective against things that do aerobic respiration or fermentation. And we do aerobic respiration, but anaerobes are tough. It's a different kind of metabolic process. The other, and you might remember for you having me for AP1, we talked a lot about something, as well as here, called glycocalyx, that sugar shell, slime layers. Bringing about, asked a question on the first exam about that. There's reason why I asked those questions. It's good for anaerobes and it penetrates the glycocalyx. That's the good news. Bad news, horrible diarrhea. In the first place, they called it pseudomembranous colitis. The reality was it destroyed a number of the gut bacteria and really allowed the C. diff to flourish. So it really was a big problem. I've had to use it because when you use orthopedic implanted materials, whether it's artificial joints, pins, wires, screws, what happens is they form a slime layer on that material. Almost all, most of them are stainless steel or modifications. And if infection gets in under that, it's very hard to penetrate. So I used it a lot on patients and had to deal with a diarrheal complication. So that's it. The interesting thing is it does work well on community-acquired MRSA if what you'll see is my first choice, the sulfa drugs, doesn't work. But again, you have to take all those precautions you would for diarrhea. It is, I had a lot of use support. I'll explain what we use about anaerobes very, very shortly. But that's important to remember. These last two are what I call the special category. So this is what I call streptogramins plus. They're here. These last two. The one is called linezolid. It's in this category. They take it from the family name Linecolid, and the other are streptogramins. Even though all of these are effectively bacteriostatic, what's interesting is they have been formulated, they're more advanced. Back then, we have more advanced ones now that were designed pretty much for some of these very hard to get to MRSA cases, both the community acquired, and now we're getting to ones that work for the hospital. The problem was back when I was prescribing, health insurance was a big problem. These were extraordinarily expensive. People just like, I don't want to hear that. That to me, that's a really significant issue. That they are, you really had limited availability. because really they were killed. But I do not know exactly what they're using today. They tell me these fourth and fifth generation cephalosporins are getting a lot of use. I'll buy that. You're going to learn about all that stuff, and you're going to take pharmacology. It was interesting. Remember we talked about synergistic relationships. That two of them work better together. They took two of these streptogramins that targeted protein synthesis, and all they found someone that was actually bactericidal. And you can see what they work at against resistant strains to beta lactams, the vancomycin. They're pointing to a person and related for both. So you should remember those topics as well. And then down the road, you'll see some of the specifics. I tend to use the topics rather than the names because I think it's the group names rather than the individual names, because you don't need to start memorizing all those. So that's kind of the pecking order for numbers 2, 3, and 4. Vanco we already did. Let's get to the other one. It's coming. But not yet. I'm running out of room. This is really important. This is a very good teaching list. So, you guys in lab did your cultures and sensitivity and blah, 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 right? Measured the diameters, IS and R, all that good stuff. By the way, it doesn't always work, but it works in the laboratory, okay? The name for that is called in vitro. It means it worked in a test tube in the laboratory. In vivo means in something living. The fact that something works in the lab doesn't mean it's going to work in real life. A lot of times you'll prescribe the appropriate antibiotic, you look at the culture, it's supposed to work, and it doesn't. And this is the classic example, fluoroquinolones. They are a relatively new one. I understand you tested either this one, ciprofloxacin, known as Cipro, and its other name was nalidixic acid. That was earlier. Nalidixic acid. You might have had discs for that. We used to have. I was there when Cipro, maybe here, my wife, I call it Cipro, my wife calls it Cipro, we argue. When they first came out with it back in 1985 or so. And the pharmaceutical salespeople came and said, we have the new agent. It's bactericidal, works on gram negatives, works on staph, and works on strep. We have culture evidence. They'll show you the data. And within 2 years, if you wonder what doctors do when they go to conventions and they're sitting around having lunch or in between lectures or just, talking about different stuff. I can remember this like it was yesterday. Lou, are you using Cipro now? I said, yeah. What do you use it on? I said, well, I used to use it on staph and strep. It doesn't work. I stopped, and the other doctor would say, I'm not using either. It only works on gram negatives. It works in the laboratory, in vivo. It does not work in vitro. Within 2 years, we knew that. The pharmaceutical manufacturer wasn't going to own up to it until later, until finally, well, why aren't you writing for our drug for staph infections? It doesn't work. And they altered the indications. The fact that anything works in the laboratory doesn't mean it's going to work. The fact that any medicine works on a patient, on 10 patients, doesn't mean it's going to work. The human body is it's a different playground. We're all different. And that's sort of the underscoring thing with regard to that. That's there. So, and it's interesting, it works on gyrates. It's like unwinding and unwinding, coiling and uncoiling DNA. So this is no longer protein synthesis. What we're now working on here is DNA, and this one, rifamycins, work on RNA. Where we use Cipro. Cipro is my go-to drug for gram negatives. I was in the hospital with a salmonella bacterial infection, different than food poisoning, much worse. What do they give me? Ciprofloxacin. When you have, unfortunately, I've had a lot of urological surgeries. I all told you about bladder cancer. What's the medicine I would be given when those were problems? Ciprofloxacin. There's other names for it. It's even kinds of pneumonia that are gram negative. There's agents that have been utilized for that. So, I mean, this is a category with which many of you will become highly familiar. This, hopefully, you will know. Rifamycins work on RNA. Okay. This is one of the many anti-tubercular drugs. This has tremendously nasty side effects. You'll see when we get to tuberculosis, we have to use, it's mandatory with active tuberculosis to likely treat for a year, and you have to take 2 medicines, and about every 2 months, switch them with 2 other medicines. Resistance develops that quickly. This one works as an oddball that works on RNA. It is the side effects are awful. The other thing I've seen it used on is bacterial meningitis. You can put side effects behind when someone could die right away. We'll deal with the side effects if somebody's going to die. So it's all about what's number one hit parade. If you watch the pitch, the first thing I said, I turned to my wife, the first thing they tell you, stop worrying about the fact that they got a cut here that we're going to have to sew up, and you got bone exposed. All of a sudden, they're in the middle of a heart attack. You always have to address what's going to kill them first. First thing they told us. Pretty up the other stuff. You'll get to it, but there's a pecking order of priority of those type of things. Rifamycins are like this. The name is called rifampicin. You will see it. I don't think it's on this exam, but I'll double check. I was thinking about the study guide this morning. I will get it to you. Okay. One of you, I'm sure, will remind me. And we'll get to more of the tuberculosis things. This is the other one for gram negatives. This is where clindamycin has a lot of problems not for gram negatives, for anaerobes. This one is a very, very good agent. And I'll give you the single most important thing that you're going to be using it for, C. diff, and it's called metronidazole. It's been around forever. Metronidazole or flagyl. Yeah, it is the drug of choice for C. diff, barring somebody being allergic to. The biggest, they'll tell you about different problems. Biggest problem is headache. It's an interesting agent because it's not just an antibacterial agent. It's also an antiprotozoan agent. There aren't a lot of these that cross from prokaryote to eukaryote like that. It's because it targets anaerobic metabolism. C. diff is a strict anaerobe, and if you're why I'm familiar with it, with people who have contaminated well water, which we have an abundance of here as we get rural in Pennsylvania, they get a thing called giardiasis and amoebic dysentery. Those are all anaerobes. As I mentioned to you before, Trichomonas vaginalis, which is arguably the most prominent anti-protozoan sexually transmitted disease. Millions and millions of new cases every year in this country are treated with this. So we're going to spend a lot of time looking at that. When I had C. diff, I had it back in 2005. You get the picture, I wasn't very healthy. After that salmonella in 2006, I guess. But that C. diff I had in 2005, my kids, when they were little, 40 years ago, in 1986, I went to do a seminar. My first wife and I went out of town to do a seminar. I was going to be for 4 days private, getting ready for my orthopedic board exams for board certification. And my office manager watched our 3 little ones. She's her husband. They loved her. She's wonderful. Out on the farm animals. Problem with the old well water and septic tank. All 3 of my kids had tons and tons of diarrhea. They got giardiasis. They had to take this thing. But with little kids, they have this happens with kids a lot. They have liquids and they'll flavor them. So if the kids will take the liquid, they're not going to. Those are pretty good. But I mean, you have liquids like pineapple and bubble gum and all that type of stuff. It's kind of like amoxicillin, those big chewies. You know what I'm talking about? You've never had an earache? You're healthy? My daughter had not one, but two sets of teeth. I maintain that's why I didn't hear you, Dad. Suppose not go out with that bum. Don't spit that up. It looks bad. I'm teasing Josie. So really important. Remember that list that was before? These are the combination solvents. True anecdote coming your way. The beauty of this is they're called folate inhibitors or folic acid inhibitors. We don't have this pathway in our bodies. That's why it's kind of like peptidoglycan. We don't have peptidoglycan. We need folic acid. It is mandatory for our bodies to do business. It's really a B vitamin. It's in that family. You take a multivite every day, covered. Folic acid, as many of you will learn, was extra. It's the reason for prenatal vitamins, is we had to make sure moms were getting the appropriate vitamins, particularly folic acid. Because back in the day, we had a lot of kids born with spines that didn't fuse properly, and pieces of their nervous system began to protrude. It was nasty. I mean, this was back in the 50s and 60s. That was because of folic acid not being there. That they're going to ask you about. That you're going to have to know. But bacteria make it themselves. So this is one of those examples. Another question that maybe you might have seen about competitive inhibition. This is a competitive inhibitor, a lookalike drug. Here's what we need with the bacteria need to make folic acid, fancy name para-aminobenzoic acid. Here's sulfanilamide, that powder. That was around in the 40s. They look almost identical except for the substitution. Effectively, this clobbers the enzyme. So they took a variation of this drug called sulfamethoxazole, and they mixed it with another one called trimethoprim in the same general category, blocking this enzymatic pathway, and bang, we have a pretty good agent that it does not have a lot of side effects. Now, when they first started to use this and why, which had been right for many, many years, the only reason we used these combination sulfa drugs was to treat bacterial bladder infections, particularly in women, which are relatively frequent for any one of a number of reasons. There's nothing unusual. It was a twice-a-day generic pill. It's been around for so long, either called Bactrim or Ceftra, and very inexpensive. Pharmaceutical companies hate it when there's a good drug that's inexpensive and not making any money. Absolutely true. Easy compliance, one pill twice a day. My wife took it for one. She turned out to have an allergy to it, can't take it. That's really about the contraindications that were there. When it first came out, they used it extensively for urinary tract problems, gave it to my grandfather back maybe in the 50s, and it crystallized in his kidney and he lost the function of one kidney. Now, understand, by age, he didn't die until age 86, and it was because the other kidney eventually, but he was 86 years old, let's be clear. Okay, so maybe by today's standards, that's different. But back then, that was a pretty ripe old age. He died in 1976. So now what they found when MRSA reared its ugly head, basically, it's like, what do we got in the medicine chest? They looked to see what antibiotics they had, and they said, we've got to test them all. Maybe we'll get lucky and something will work against MRSA. Guess what? The combination sulfa, this relatively inexpensive agent, worked really well on MRSA. And so that's why, if you remember that list, this is the first choice for community-acquired MRSA, and we work our way down. We go to the lincosamides, clindamycin, some of those special new ones, like the Synercid, those synergistic agents, and then vancomycin. Again, I'm not going to ask you about that because maybe the pathway has changed. I suppose it's modified over the years, but it gives you an idea of this battle we're fighting with. And that's really the frame of all of what I'm talking about in this whole unit is resistance, resistance, resistance. That's there. So these are really very useful that are there. We don't have the enzyme, often used to treat UTIs. Now we use this combination, and they show it to you. Membranes, not a whole lot that we use. because polymyxin B is so strong it's used topically. Occasionally, we will have such a resistant gram-positive that you'll hear about dactomycin. Again, these ones that you start to learn about, particularly in pharmacology, what we call drugs of last resort. We don't have choice. Almost done. This brings us to the last topic for today. I'm starting to do resistance, but I didn't want to do too much. I didn't do too much in the other group, so we'll start with it on Monday. I want to get through all of this Monday, Wednesday, latest, and then I'll start the other unit about diseases, how they spread, the impacts they have inside generically. And this last one is I'll just put TB, anti-tuberculosis. There's so many of these because it's so easy to develop resistance. It's all about it, all of them, except for rifampicin, which targets RNA. Should be able to remember the R and the RNA. Target, remember the name, it's called Mycobacterium tuberculosis. That capsule, that mycolic acid, you did the acid fast stain in lab. The mycolic acid capsule is the target for nearly all of these other agents. Sorry about that. So we have, and again, you have to use at least 2 of these for active tuberculosis, typically for at least a year, and about every 2 to 3 months, you change them out. Okay, you have what are called first-line drugs and second-line drugs. When we look in more closely at the disease tuberculosis, you'll kind of get an idea. They classify them as one is extremely drug resistant, one is either there's drug resistant, extremely drug, some type of categorization. TB is a big problem. It just came out with a major study in New York City. It's about overcrowding, where they had a remarkable upswing this year, this calendar year 2025, in active TB cases. This kills people. So, and we'll talk about how it does and all that good stuff. Very familiar. I can't recall encountering an active case in my practice. Okay. But you will talk about first line drugs and second line drugs and all of those types of things. They are all, years ago, isoniazid was something, if you were just exposed, you have a thing called latent tuberculosis. If they found out you were exposed, tested positive, and there was an exposure and whatever the criteria are, they gave you this. I told the other class, I had this really great student. Turned out, back in 06, when I was teaching at Chatham for Shadyside School of Nursing. And it was like, every time I gave a test or a quiz, she either got an A or an F. There's no in between. I remember her name. Not off the top of my head. The first name just gave me the last name. And I go, is it because you only study every other time? She goes, oh no, it's my isoniazid. What do you mean? She goes, well, she turned out she had an aunt who she was the primary caregiver of, who was in the process of dying of tuberculosis. And she had been exposed because she was treating it. It's a constant exposure every day. And they were giving her this once, and she, every so often, it was fine, it's fine. And then she keeps, and some days it was like, I can't function. And I said, did you ever think to mention this to me? And, maybe you might ask me because you were sick and couldn't take the test. If nothing else, you've learned, I'm pretty reasonable about it. Not everybody's going to be, but I am. And she goes, well, I didn't really want to bother you. Great. Thanks a lot. Try to remember her first name. That's killing me. Well, we'll figure it out. Nevertheless, that just gives you an idea. Nowadays, I don't think they do that. I think now, if it has any degree of activity, if there's anything to suggest it might be becoming active, they do the full therapy. This you did in lab, don't worry about it. I don't want to bother you with it. You've seen those before. These are some prettier ones, blah, 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 blah. And again, we'll start about resistance when we come back on Monday. And there's not as much left in this chapter as you think. It'll surely be done by Wednesday, I think. Bye-bye. Have a great weekend. Nice to see the Friday Club in action.